Now we'll move on to case scenario-based discussions regarding radical nephrectomy and IVC thrombectomy. I would invite Dr. Raghavan to enlighten us about how to control the vessels while doing radical nephrectomy. On right side and left side, are there any differences? What are the tips and tricks to control these vessels? And also I would request him to talk on the role of vascular staplers, when to use, when not to use, pros and cons of vascular staplers. Over to Dr. Raghavan. Dr. Raghavan, are you online? Dr. Raghavan, can you hear me?
Raghu, can you hear me now?
Yeah, good evening. Welcome.
Good evening, Raghu. Good evening to all. Opportunity. Raghu, I'm going to share my slides for a quick review.
Yes.
On this. Okay. Hope all of you can see this. Yeah.
Yes,
can you see my share screen?
Yeah, please go ahead.
Yeah. Okay. So my remit was very simple. What will we do for a right and left side in terms of handling the vasculature? The most important key, as far as I'm concerned, is that you have a good quality scan so that you can plan it out properly. It's all about planning before you go inside. Doing it as we go along may be a very old story, but it will not be a very wise story. So in the right side, first is adequate exposure. What I tend to do is look at IVC and trace the IV, the lateral border of the IVC from the point of infrahepatic till the point of the IVC bifurcation. And as you climb up the IVC, you will find the renal vein. And what you need to do is just lift the renal vein with a retractor, and you'll find the artery there to find it. So the great vessels are always going to be the guide for you as far as finding the vasculature in the right side. And in the left side, you do the same thing. Here you have an additional gonadal vein, which you can use, but I tend to use the aorta as my point of identification to work my way up. So it's all about exposure and tracing the great vessels up. In case of bulky tumor, in case of venous thrombus or a lot of nodes in the IVC area, you can find the right-sided artery at the interaortocaval point. I use it a lot when I'm doing the IVC thrombus on the right side. So this is a very useful tip. It just needs a slight bit of patience to do it. You can do it in the minimally invasive technique as well, not just necessarily in the open technique. In case of difficult hilum, obviously in open surgery, you have a finger to have a tactile feel by which you can sloop around the artery and take a tie around it and tie it off. This is a very famous thing that all teachers will teach the students. Or worst come scenario, in a very bleeding situation, you can have a mask clamping as well. For the beginners, in an emergency situation where you suddenly find bleeding, the first thing to do is not to panic. Inform your anesthesiologist, make sure that adequate hydration and blood products are available, make sure compression of the hilum is done, and do it in a controlled suction, pack, retract, dissect, and get your things sorted out. Please do not do blind clamping, both in the right and left. This is where the duodenum, the choledochal areas, or the pancreas head all get damaged by your blind clamps. So don't do that. Of course, these are the sutures I use. Of course, you will follow whatever sutures that is comfortable for you to use. In terms of minimal invasive surgery approach, once again, adequate exposure, same principle. Even for my robotic surgery or my laparoscopic surgery, I will lay the IVC and aorta bare, the lateral aspect, in order to make sure adequate exposure and go to the vasculature. If you go that way, you will inevitably make sure you're going to the axial vessels. If you're going a bit close to the hilum, you'll be still finding all the branches of the vessel rather than the axial vessel. Obviously, the left side, the gonadal will be very useful, and the ureter will be lifted up because you're doing a radical nephrectomy. And what I tend to use in a minimally invasive surgery is that make sure that you go posteriorly, especially the vein, because without your knowledge, you will find that there is a lumbar vessel that is going down, and suddenly you'll be hitting it and you'll have a big bloodbath there. And therefore, make sure you gently go around, make sure you have adequately exposed there before you start applying your Humalog. I tend to use Humalog both in open and robotic surgery. Of course, everybody has their own choices. You can even use hand ties or even titanium clips. I personally don't prefer titanium clips. I am for Hemalocks more than titanium clips. And of course, in very difficult situation, or you're going to do partial, you can always use a laparoscopic Statinsky clamp, even though I generally don't use it. Last point, which Raghu asked me to talk about, is the staplers. I promise I have not used the staplers at all for the vascular control. I have seen staplers used by my teachers, and we have had at least 2 occasions when the stapler malfunction happened, and we have to open and sort the whole thing out later. And at that point, what happens is you are applied it to sort it out. Having said that, my experience with staplers is limited. Others can enlighten me as well whether they use it more, but generally I tend not to use the stapler. The most important cons as far as stapler is concerned for me, in my experience, was the malfunction, bleeding, and conversion to open. There's also a discussion about AV fistula, even though I haven't come across that. Thank you.
Thank you, Raghavan. How frequently you discuss with the radiologist before performing surgery to understand the vascular anatomy pre-operatively?
I will always discuss with my radiologist 100% of the time, because especially in a partial, when you have more than one vessel, you go and sit down with the radiologist and discuss and understand the vascular anatomy well. In cases of partial, especially difficult partial, in cases of node dissection, and in bulky tumors, you go and discuss with your radiologist. It makes your life a lot better.
This is very useful information for the postgraduates. Always discuss with the radiologist, understand the vascular anatomy before planning the surgery itself. That will help you to perform the surgery in a better way. You can prevent complications. Thank you, Raghavan.
Thank you. Thank you, Raghu. Thank you. I'm online.
Thank you. So now we'll move on to management of the large tumors. While performing radical nephrectomy for large tumors, inadvertent pressure or overpressure, exerting pressure on the kidneys sometimes can cause graft spillage of the tumor. So I request Professor Ranjan Day to talk on how to manage this spillage. Is there any way to is there any way possible to prevent this spillage? Hello, Dr. Ranjan, are you online?
Can you see me?
Yes.
My point is the incidence of the spillage is very uncommon in today's surgery, and in case of the partial nephrectomy, it can happen only if we inadvertently enter the tumor mass. To avoid this, we can use intraoperative ultrasound to get rid of this. And in case of the cystic tumor, we have to be very sure that you are taking a margin beyond the tumor to get rid of this complication. And at the same time, this kind of spillage can also take place if a large tumor has been, morcellation is done in a large tumor for taking out from the abdominal cavity. So if you can avoid morcellation, if you can take the help of the intraoperative ultrasound and be careful about the margin of the tissue around the cystic tumor, we can avoid the spillage.
If it has already spilled in a large tumor, how are you going to manage? What are your advice? What is your advice?
Advice is, first of all, you will have to take care to remove the entire spilled material from the abdominal cavity. You will have to wash it with distilled water if available, and it has to be done to make it very clear that no residual tumor is left in the abdominal cavity. And after that, if we are satisfied with the amount of clearance that no further surgery is needed on the residual renal tissue, we can come out and close the wound, taking care that there should not be any spillage of tumor material on the wound. And this group of the patient are usually kept on close observation, explaining that there may be a chance of local recurrence if the spillage is huge, and we have to ask the patient for a regular follow-up with early radiological evaluation.
Do you advocate adjuvant therapy for these kind of cases?
The recommendation for adjuvant therapy has come in the recent literature, but there is also controversy related to it. Different studies have come out of which your extract trial have given some evidence that the sunitinib has an advantage in preventing recurrence in the wound or this kind of a thing, especially if the cases are there is high risk of recurrence, so sunitinib can be used, and they have got also FDA approval for this. But there are many other studies which is not supported this view. So there is still a controversy whether we should use this sunitinib as a recommendation for the spillage management or not.
Thank you, Dr. Ranjan. Now I request Dr. Rajiv TP to tell us more about Chylous ascites. All of us must have seen in our routine practice when we perform radical nephrectomy, particularly on the left side, and if dissection of the lymph nodes or perihilar nodal dissection is relatively more, we come across this Chylous ascites or the leakage of chyle through the drain. So I request Dr. Rajiv TP to give us more information on how to prevent this Chylous ascites and how to manage this. Dr. Rajiv?
Thank you, Raghu. Chylous ascites during a radical nephrectomy, especially in a locally advanced tumor, as you have cited, when there are a lot of hilar nodes. This is basically because of injury to the main cisterna chyli or the one of the main tributaries to the lumbar channel. This happens when there is dissection in the hilum as well as towards the adrenal area. So in such large tumors, or when you are going to do a lymph node dissection, one has to keep this in mind. And whatever the lymphatic channels comes across, if it is smaller channel, you have to carefully coagulate with a bipolar, or if there are bigger lymphatic channels, it has to be either clipped or ligated. Sometimes even after careful thing, later on, chylous, there may be unrecognized injuries which may present later on as a chylous ascites, as you have cited, as a thing of after a few days of surgery, leakage of milky fluid through the abdominal wound or the abdominal drain. So this can occur, but one has to be, and if somebody has some doubt during surgery, there is a technique like you can give butter through the Ryle's tube so that leakage of the milky fluid can be seen if there is any injury to the lymphatic channels, and it can be tackled at the time of surgery itself.
Thank you, Dr. Rajiv.
Raghu?
Yes, sir.
Can I make a comment on this?
Yes, sir. Please, sir.
Yeah. See, treatment of chylous ascites or chylous leak can be very tricky sometime. I have seen this during RPLND and radical nephrectomy also. And in these cases, when I have opened the patient and used butter, especially Amul butter works better than the mother dairy butter, which I have told you before also, because there are 309 people are logged in. So they should know that Amul butter works better than the mother dairy butter, and you can see those channel and repair with the proline or anything. But the thing which have worked recently for us, and we have published that technique also, it should be there in somewhere in the radiology journal, and we have done 4 or 5 cases like this. Our radiologist injects the lipodol in the inguinal lymph node, and from there they actually show the lymphatic channel, and this acts as a coagulative agent also, and most of the time they heal. That's what I've seen. But after using lipodol, we have not explored any patient till date in last 2-3 years.
Yes, sir.
Raghu, can I come in?
Please.
Yes.
Actually, we have 6 cases of intractable chylous ascites. That is after radical nephrectomy, after lab donor nephrectomy, and this we have gone into a graded manner, like putting them on fat-free diet, or if they have to take fat, it's a medium chain fat, and giving them somatostatin injection.
Wonderful study, yes.
And with that, some of them have significantly improved. And if that doesn't work, then put them on TPN for some time. So out of 6, 3 could be managed with this, and 3 patients couldn't be managed, and they were losing weight, and their ascites is causing a lot of problem. So we went back, and we went back laparoscopically. We have video of those patients, and we could see that chyle is leaking, and there are big holes from there. Chyle is leaking, and we took a Vicryl sutures and underrun it, and with that bleeding, this chylous ascites has stopped. And these 3 patients had somatostatin, diet modification, even TPN.
Dr. Anant, next time try lipodol.
Yeah, I know.
Require,
no, but
you will not require re-exploration.
No, I have not done lipodol, but
Yeah.
I doubt that
No.
cause,
Why are you doubting?
it can cause say, fibrosis that stop it, because lipodol has been used previously for malignant.
You try it out and then let us know.
Yeah, I have not tried it, but
You try it out.
But we have used it in 3 patients. We had to operate them.
Yeah.
Raghu, one more point I wanted to add. Can you hear? So one of my patients in which we couldn't control with any of the other method, our radiologist could puncture the cisterna chyli and embolize the leaking lymphatic. It is also possible.
Yeah, even acrylic material has been used by radiologists to control this. So there are various methods. Either percutaneously people have tried, radiologists have tried, or even laparoscopically they have tried. This lipidol works better. Our interventional radiologist tried on several patients, so it works really good. Thank you. We'll move forward now. While performing large radical nephrectomy, particularly on the left side, we have seen in the literature, inadvertently we have ligated or clipped the superior mesenteric artery. It's a catastrophic situation. So I request Dr. Gagan Prakash to tell us more about how to avoid injuring the superior mesenteric artery, or even after clipping, how to salvage this. This is very rare situation, but we know it is there in the literature. I request Dr. Gagan Prakash to tell us more about preventing this injury. Dr. Gagan?
Thank you, sir. So, before we discuss about it, let me acknowledge that this has happened with me once during a robotic radical nephrectomy for a very large tumor with some lymph nodes. And as Dr. Raghunath mentioned, once you have this kind of a thing, first of all, the first thought you get is ki aisa bhi hota, you would never think that something like this can happen. One should pray that it never happens from you. And so one of the issues is that this is a known complication. It's there in the textbook, but it is underreported. So, we may not really know how common this is, but it's a known thing to happen. So it's very, very important that we learn from the people who've undergone this really, really dreadful complication and get some opinions. Now, typically the tumors where you have to be very, very mindful about this kind of a thing happening are bulky left-sided tumors, often with our lymph nodes which are para-aortic, or sometimes, if there is an infective component either to the tumor or if the nephrectomy is done for an infective reason, these are the scenarios when you can have this kind of problem. The second thing is that, this is much more common in minimally invasive, either laparoscopic or robotic surgery compared to open surgery. Now, there are 2 kind of scenarios which can happen. One is that you have an injury to the superior mesenteric artery. And the other is that you mistake this artery for the renal artery and then ligate it or clip it. And then you realize later that what has happened. Now, typically, I think the most important thing over here is mindfulness of the fact that in these scenarios, this kind of a possibility is also there. So the first thing is that in these tumors, which are large bulky tumors, lymph nodes, make sure that you have read the CT scan very well. Please understand that the superior mesenteric artery, the celiac artery, the left renal artery, and the right renal artery, particularly the first three, the left renal artery, the superior, and the celiac artery, are in very, very close proximity. The celiac and the superior mesenteric artery are probably less than half a centimeter. And the superior mesenteric and the left renal artery are also close to 11 mm is the average distance which has been described. Now, the CT scan should be read also from the point of view to know if there are any accessory arteries, because if it's not there and you happen to see a second artery, you have to be very, very careful if this could be the SMA. The second thing is in minimally invasive, although most of us tend to use a 30-degree scope, but my personal experience is that when you are working around the aorta in those para-aortic nodes, I think probably a 0 degrees, with a 0 degrees, probably the chances of going in the wrong planes might be a little lesser. Planes is again important. So, the problem happens because you enter into a wrong plane when you have got the colon down, or when you are trying to go into the plane between the aorta or the nodes, or between the aorta and the kidney. Now, one of the things again for prevention of this is the two-window technique, which Dr. Mallikarjun had described in one of the IGU. I think that's very, very useful to make sure that you actually seen the vessel from where it is, originating from the aorta, and you've seen the vessel which is where it is entering into the kidney. So typically, the moment you feel that the axis or the direction of the vessel is not right, then you should think yourself whether this could be something else other than the renal artery. Now, if it's an injury, then you have to, if it's a minimally invasive, then you obviously have to have your drills on, and you have to have your protocols on where you can increase the pressure till the buy time to get the patient in the supine position and then open. If it's a ligation, then you have to be really lucky enough to identify on table that this has happened. And this most of the times happen because once you ligate the SMA, you would get the actual renal artery later on. And, when your vein is not emptying well, you can realize that there's something else. And eventually most of the reports in the literature also say that an on-table recognition of this happened. And after opening the patient with the vascular team on board, the kind of reconstruction that needs to be done would be decided on table. So either most of the times you will require a interposition graft to repair it. The patient that we had a problem, I was lucky enough that the site of the superior mesenteric artery has zones actually, and depending on the site at which the injury happens or the ligation happens, sometimes you might have collaterals and not have a problem. The patient survived and has been doing well. Thank you, Dr.
In the literature,
did you require grafting between the aorta and SMA?
Yes, sir. We did require. But what had happened was that the graft also actually thrombosed, but we realized that there were some collaterals before the site of the injury. So, the patient did not have problems.
Yeah, at times if collaterals are there, you don't recognize that, and nothing will happen to the patient, but this is extremely rare and you should be very lucky. I would like to hear from Dr. Rahul sir, and Dr. Rajiv Sood is also online. So anybody's comments, seniors, experts comments on this, because this is a very rare scenario.
Oh, I remember, I think you will remember also.
Yes, sir.
We had one patient with a big tumor in the beginning of our career on laparoscopic surgery. And we actually applied a Hemolock. And then I realized that this is SMA at that time, and we could open immediately and remove this thing, Hemolock. But I have actually, after this, when I was doing a robotic radical nephrectomy, at that time also, I was almost about to clamp the superior mesenteric artery, because I thought this came in front of me from left side, it come in front of me very easily.
Yes, sir.
But then I could not see the renal vein, left renal vein. And that's the actually catch. You must see left renal vein before actually deciding any clamp on the left renal artery. So that time I realized that it's very easy to make, especially when you are on above the renal vein and upper border of the renal vein. You will see some artery and you will think that this is the renal artery, left renal artery. You will be starting dissecting. It is very similar to left renal artery, and you can easily clamp. This is not it is not the thing which you can't do. Anybody can do if he is not, vigilant. Thank you.
I can tell you. Can I tell you a very interesting thing? In 1990, hello?
Yes, sir. Yes, sir.
In 1990, I was in Melbourne, and Royal Melbourne, David Johnson was the chairman of urology. And he ligated a superior mesenteric artery. And but that patient finally died, and he has to resign from his post. That is the one thing. So this is 1990, and since then I knew that it may happen. So whenever we have large tumor, we are very careful about it and keep telling it, just look where it is going. But I can tell you, in lab donor nephrectomy 3 years back, superior mesenteric artery was cut as a renal artery, and we opened immediately and then put a clamp, and we had to put a graft between aorta and superior mesenteric artery. Patient survived. And it is very, if you are doing robotic surgery or anything, you can use ICG and you can see the bowel perfusion also, that whether it is good or not. And if the bowel perfusion is good, you can get some idea about it.
Thank you, sir. I would like to hear from other experts. Have they come across this situation? Because this is extremely rare. We would like to hear from, yes, Ginil, please. Dr. Ginil, you have any comments? Any experts can comment on this.
Ask him to unmute. He is not unmute.
Yeah.
Yeah, now.
Hello.
Yeah,
one point I want to highlight what Gagan has told is, for me, it happened in a patient who had an IVC thrombus with a lymph node. So when there is a lot of lymph nodes are there, we can go wrong and can get the superior mesenteric. That is one point. Second point is, if you are clamping a vessel anterior to vein, renal vein,
exactly,
and especially at the midline, just make it double sure that it is not superior mesenteric. So that is the most important point I want to highlight.
Yeah, thank you, Ginil. These two points are very valuable. So let us move on. Whenever we come across a large tumor with large perihilar nodes, radical nephrectomy is challenging. So I request Dr. Anant Kumar sir to give his wisdom and ideas how to manage the hilum while performing radical nephrectomy with large perihilar nodes. Dr. Anant Kumar sir?
In this situation, I always go open surgery, and we do keep the patient supine and give subcostal incision, and incision may get extended to the other side little bit, or you can also extend up to the GP sternum and you can cut the part of the cartilage, and then you get a very nice exposure. Then operation becomes transperitoneal. When you reflect the bowel, then you can get a very good exposure. Your gate vessels are in front of you, and kidney is also there. If it is the right side and there is a lymph nodes are sitting, the best place to get the artery is what Raghavan has described, which we have been doing for long. Go between aorta and IVC, see the left renal vein, lift the renal vein up, and in open surgery you have a tactile sensation. You can feel the pulsation, and then you can dissect. There is a lot of lymphatics at that situation. Once you take away the lymphatics, you will see the artery. Always make sure that it's coming up the aorta, going to the right behind the IVC. Then it is only the renal artery, and then you tie it there. And once you tie it, the blood flow is stopped, and you will be having idea whether it's single artery, double artery by looking at the CT angio. And left side also, you lift the lower pole and then just go just side of the abdominal aorta, and when you go up to the renal vein and you start dissecting it and you take care of the lymphatics, invariably you will get this. And sometimes if the lymph nodes which are coming and sitting, you may have to remove those lymph nodes to get to the artery, and that's how you will get the artery and then you get the vein. and most of the time you tie the artery, that blood flow has stopped, and then you take care of the vein, and then once the vein is gone, then you have a better view of the artery, and then you can have dissect more, and then have 2 proximal suture, 1 distal suture, and then you can cut the artery. So tying up the artery is the first step, and then you can do rest of the dissection.
So to understand this vascular anatomy, better to dissect out the lymph nodes, then understand the anatomy, where is the artery, where is the vein, then you proceed. That way you would like to proceed?
Yeah. So if there are 2 big lymph nodes, then probably, I don't know, this is an operation worth doing it. But if there are few lymph nodes, yes, you can take them out. And you can do the lymph node in block, or you can do whatever comes out, then one by one you can remove it and then clear it. But if you cannot go to the artery, then you have to take care of the lymph node first to create a space to go there.
Yeah. Dr. Raval, sir, do you have any advice in this
No,
situation?
I think Dr. Anantkumar has said perfectly the same thing. I'll do open surgery and, develop a plane between the node and define the anatomy, define the vessel, and then dissect them out like you do in RPLND rather. Not as do exactly in RPLND, you need not to ligate the lumbar vessels if they are, not coming in the way. Otherwise, dissection is same.
Thank you, sir. With this, we have completed the technical aspects of performing partial nephrectomy and radical nephrectomy. We will move on to the management of IVC thrombectomy. I request Professor Amlesh Seth to throw light on these aspects of performing IVC thrombectomy. Is there any difference in the dissection while performing IVC thrombectomy for right renal tumor versus left renal tumor? That's number 1. After venotomy, while extracting the thrombus, if spillage happens, how are you going to manage? The third point is air embolism or carbon dioxide embolism while doing minimally invasive surgery. Dr. Amlesh Seth, sir? Dr. Amlesh Seth, are you online? You have to unmute. Dr. Amlesh Seth? Can you hear me, sir?
Yes, yes. I was actually muted by the host.
Right.
Okay.
Please go ahead, sir. Please address these 3 points.
Yeah, sure, sure.
If you have slides, you can share.
Yeah, I'm beginning.
If it is difficult to share, just let us know. We will move on. We'll come back to you later. Can you hear us, sir? Hello? Dr. Amlesh, sir? We will move on. May I request Dr. Hemang Bakshi to address these issues? Hello? Dr. Hemang Bakshi? How do you manage excessive bleeding on venotomy while performing IVC thrombectomy? Once you make a venotomy, if excessive bleeding is there, how are you going to manage? And when do you...
Raghu, can you hear me?
Yeah. Please go ahead, sir.
Okay, so I have just got a couple of slides, if I can.
Yeah, please share your slides.
Share for both situations.
Yeah. Please share your slides.
Yeah, I'm trying to do that. So the slide share screen is a problem. But anyway, so what I'll do is I'll just talk over if that's all right. Now,
Yes,
the first thing is veno top.
The share screen.
Yeah, I'm clicking on the share screen and this is what it pops up. So I don't know, it shows basic, advanced. It doesn't show the computer main screen. So I don't know why that's happening.
There is at the left lower end, there is also share. Click that also.
Okay. I can't see that working. Let me try it once more. Can you see this now? No. So my computer screen is not getting hooked up.
You can speak out.
I'll speak on, yeah. So the first situation that you are doing a vena cava thrombectomy and it's bleeding. It's bleeding like hell. So you just made your incision in the cava. You have got all your vascular controls in. The clamp above the thrombus, the clamp below the thrombus on the cava, the opposite renal vein, and on the right side of the artery is necessary to be clamped. You have all your vascular clamps in place, whether it's open or robotic or laparoscopic. Now you open the cava and it starts bleeding. So the surgical team realizes this first, that it's bleeding. You are already alert. First thing you do is ask the anesthesiologist that we are losing blood fast, get the blood in, get the open surgicals back up ready, the circulating nurses and everything to get the open tray ready. And then try to identify the problem. Why is it bleeding if the vascular clamps are in place? So first thing you check is the clamps, whether they are inadvertently not slipped off. So one of your bulldogs or one of your Rommel tourniquets might have slipped. You don't want that to happen, so you can reapply. If you feel that the clamp pressure is not right, you check the venous clamps. That's the first thing to do. Second thing is, most commonly, there would be lumbar vessels which you might have missed, behind the cava especially, and those lumbars might be pumping in blood. So you again lift the cava, do the retrocaval dissection. And of course, all this is being done when the first thing you do is tamponade the bleed. So first thing is, whether you are doing open or minimally invasive, we just pack by a gauze with pressure and try and stop the bleeding. Increasing the pneumo is not going to help much, as in pelvic surgery, where increasing the pneumo in a head-low position might help. Here it doesn't help all that much. So compression is one, checking the lumbars is second, and checking the clamps is third. Sometimes what happens is, after a thrombectomy, and if after all these measures it's still bleeding, what you can do is check for a renal artery, especially in the right side, which you have missed. So the 3 points which I would highlight is the renal artery, an accessory branch you might have missed, which might be pumping in blood. Second is the clamps, and third is the lumbar vein. So these 3 points I would take care and proceed with the thrombus extraction. The second question.
In principle, you are going to control the arteries which are pumping, which you have not managed. That's number one. Number two, devascularize that segment of the IVC from the lumbars. Right? And apply the clamps properly.
These 3 points I would want. And the second question was about the
when do you excise a segment of IVC?
So pre-operatively, if you have a large tumor thrombus which is invading the vena cava wall, you can sometimes make that out very well on an MRI, which would give you the invasion of the caval wall. Now, in these cases, you would require a caval resection. A second situation where you might require is when the large tumor thrombus, no obvious invasion of the caval wall, but on Doppler examination, you find no blood flow around the thrombus. There is no space between the thrombus and the cava. You might suspect that the tumor thrombus at some point would be infiltrating the caval wall. And you should be prepared with a caval resection and a vascular team, with a patch graft or a tube graft as needed. And third situation you might require complete excision would be when you have done the thrombectomy and part of the thrombus is infiltrating the tumor, the IVC wall. You've gone ahead and done it. You think it's a small area, and when you actually take out the specimen, you find the caval lumen after reconstruction is just barely a strip. So if the caval lumen is compromised to more than 50% of its caliber, then you are probably better off putting a venous graft. So these 3 situations I would want to excise. the cava, at least be prepared for excising the cava with a vascular team standby to have put in a graft.
Thank you, sir. Now I invite I invite Professor Ginil Kumar. You would speak on the indications for grafts and various types of graft materials. Over to you, Dr. Ginil.
Before that, there was a question from the audience whether we can leave alone the
please.
bland thrombus. So I'll include that also.
Yeah.
Bland thrombus, how to deal? Actually, bland thrombus is infrarenal, and our aim is to avoid an embolization. So we can, the options are just, if it is extensive, we can either staple or ligate the IVC, or can be a cava filter. Among that, I'm just showing a picture of stapling the IVC. So when to use a graft? So that is the question you asked. So indication is more than 50% of the IVC sacrificed because of an infiltrating tumor. We have to go for a patch or a graft. Again, if a reasonable wall is there, we can just put a patch, or you have to entirely, the IVC can be resected and put a graft if it is a long, thin cava left, because it is easier to have a graft rather than a patch. So when we can, graft is essential when you have done a left renal mass and excised IVC, we have to have the left renal vein right renal vein has to be having adequate drainage. But in the left side, if you are not sure about the venous drainage, it is always better to graft than ligate, but it's an option. In left renal vein, we can ligate the, if assuming that there is a good collateral supply, because gonadal and adrenal with a connection with the hemiazygous, there is a alternate route. So, to 50% of IVC is sacrifice if you are actually having a compromised renal function where the better renal drainage is required, or if you are not sure about the left venous collaterals, or if you are doing a left nephrectomy and a right renal is only kidney, we have to graft. So what are the grafts which is available? So I have used 3 types of graft in my series of around 10 patients I used. As a policy, when there is IVC infiltration, we actually resect the segment because that is the best way to cure the tumor. So if adequate vein is not there, we usually graft, and background are the 2 grafts available as artificial grafts. Sorry, which is a synthetic
presentation. I got disconnected at that time.
Background we find
I should do next.
better because it's so even if you are actually not that much correct this thing, we can actually stretch, and it is easy to patch. So if there is only one vessel wall, it's easiest to patch it. This is the PTFE. This one is background. You can see that is actually like a net. So there are pericardium is another method we have used. If there is a cardiac surgery is opening the heart, we can get a pericardial material for patching the IVC. But bovine is a thing that is available in the market which can be used. That also we have used. Bovine is slightly costlier. Then heparin bone, different types of graft is there with bonded with heparin, then gelatin material to prevent infection. So these things are actually coming up, but 3 things we have is PTFE, dacron, and pericardium. Any more points I have to?
That's excellent, Ginil. Thank you, Dr. Ginil. Shall we move back to Professor Amlesh Seth? He was disconnected in between. Is he online?
Yes, I am online.
Yes, sir. Please go ahead.
Okay.
Can you share your screen?
Yes.
Yeah.
My screen should have come.
Yeah, start from the beginning, sir.
Okay. Okay. So the first question that I was asked was, what are the differences between the left side and the right side? There are significant differences between the left side and the right side. Left-sided tumors are always more problematic because the left renal artery is lying behind a distended left renal vein. If there is a big thrombus in the left renal vein, then identification of the left renal artery behind the left renal vein is always a major problem. And then because because the renal vein is blocked, the IVC is blocked, there will be lot of collateral vessels all around the left renal artery. So reaching the left renal artery in this situation can sometimes be really problematic. And if on the CT scan, you see that the left renal artery is difficult to approach in the initial part of the surgery, and there are lots of collateral veins all around, it is advisable to do a pre-operative angioembolization. The best time to do pre-operative embolization is on the morning of the surgery. In the morning, the first thing you do is send the patient to the radiology suite, where the interventional radiologist will embolize the artery, and then the patient can come to the OT, and your life is significantly better. It does add to the cost, but your life will be significantly better. Then the other problem is because of all these 4 reasons why the left side is a problem. Now, how to sort this out? The first solution that I have told you is that preoperative left renal angioembolization can be done. But if you think you need not do it, if you can approach the artery early, still there is another problem that is remaining. And that is, if you clamp the right renal vein, the clamping of right renal vein is not adequate, because right renal vein is a very short vein. It drains directly into the IVC, and there is a lot of collateral circulation which goes into the lumbar circulation through the adrenal into the adrenal vein. And so if you have clamped the right renal vein, that clamping is not adequate. As Dr. Hemang was also talking, there would be a lot of bleeding going on from the lumbar veins. So it is not possible to find out each and every lumbar vein and ligate the lumbar vein doubly. So the best solution is to clamp the right renal artery also. So if you are clamping the right renal artery also, you are under pressure of time, because left kidney you are taking out, right renal artery you are clamping, but still that will give you a much better bloodless field compared to clamping of just the right renal vein. The second question that I was asked about was tumor spillage during IVC thrombectomy. Actually, tumor spillage is not an issue because the tumor is lying within the vein, and the blood flow is definitely exposed to the tumor all the time. And still in that particular individual, metastasis have not occurred. There is a theoretical explanation for that. The explanation for that is that for metastasis to occur, the epithelial cells first have to transform into mesenchymal cells, and then they have to embolize, and then they have to lodge at the metastatic site, where they again undergo a reverse mesenchymal to epithelial transformation. That is how metastasis will occur. If the epithelial cells are free floating in the blood, in the IVC or in the atrium, metastasis will not occur. So, and the important thing is that there should not be any fragmentation and embolization. So you must control above. The superior control is extremely important. Superior control, inferior control, and opposite renal vein. Once you have clamped all these 3, and then after that, whether the tumor fragments or the tumor remains sticking, you can slowly, you can take out the thrombus piecemeal. You can scrape the wall of the IVC. You can excise the wall of the IVC. You can repair. You can put a graft. You can do all these things. Tumor spillage is not an issue. And then the third question that I was asked about was air embolism and carbon dioxide embolism. I am going to talk about air embolism separately and carbon dioxide embolism separately, because air embolism is a problem in open surgery and carbon dioxide embolization is a problem in laparoscopic and robotic surgery. If the tumor thrombus is confined to the vena cava, then air embolism is not an issue, because if you have got a control above, and if you have got a control below, and if you have got a control of the opposite vein, still the lumbar veins are opening into the IVC. And after you have taken out the thrombus, still the IVC is filled with the lumbar veins. And while you are closing, the IVC will remain filled. The way that is described is that the way that is described to take the clamps out is that first you should take the clamp out of the opposite renal vein. Then you should take the lower IVC clamp and then the upper IVC clamp. But I can tell you practically all these sequences are not important at all, because your IVC is all the time full of blood coming from the lumbar veins. So air embolism is actually not an issue in a situation where you are dealing only with an IVC thrombus. But if you have opened the heart as well as the IVC, like in open heart surgery, then in that case air embolism can be a problem and de-airing has to be done. But this is something which cardiac surgeons are doing routinely and they're quite accustomed to it. One of the simple ways of handling the air, if you have the facility, that you have a carbon dioxide tubing which comes into your airfield, and before you close the heart and before you close the IVC, you put in a jet of the carbon dioxide and you have a complete IVC kind of envelope in that area. But that also is generally not required. The cardiac surgeon has to be very careful in de-airing the heart and the IVC at the time of closure. Then coming to the question of carbon dioxide embolism during the laparoscopic surgery, in large series, the estimated mortality due to carbon dioxide embolism in laparoscopic surgery is 0.001, which means 1 in 1 lakh patients will die of CO2 embolism because of laparoscopic surgery. And this is an estimate for all laparoscopic surgeries, whether it is laparoscopic hernia or laparoscopic tubal ligation, etc., etc. All these series have been combined, and based on that, an estimation has been made, and that 1 in 1 lakh patients will die just because of carbon dioxide embolization, and it's actually fatal. The way if there is a rapid carbon dioxide going into the system, then it is fatal. And there are big experiments that have been done where if there is a direct IV infusion of carbon dioxide at a rate of more than 1 ml per kg per minute, 60% of the pigs died in that experiment. Thank you very much. That is the end of my formal presentation. And if there are other questions, there was a question from somebody regarding managing the bland thrombus. The bland thrombus is actually a major problem because extraction of the bland thrombus is not helpful. As soon as you take the bland thrombus out, the bland thrombus will reform. So if there is a bland thrombus, that part of the IVC has to be ligated. And in a patient who has a complete obliteration of the lower IVC because of the bland thrombus, ligation of the IVC is not an issue. The IVC can be stapled, it can be divided, it can be sutured, but the lower part of the IVC has to be excluded from the venous circulation, because this embolism, if this bland thrombus has a greater chance of leading to pulmonary thromboembolism and killing the patient. But the problem is if there is a partial obstruction of the IVC, then there are two options. Either you put in a filter, which is very expensive, and filter has its own problem. Extracting the filter is another major issue. The second thing is you go ahead with ligation, and in that situation there will be bilateral pedal edema, which will generally last for 3 or 4 months. We have seen that, and after 3 or 4 months, the patient's edema will come down with milking all the physical means. That is all that I want to say. I think Dr. Anant wants to say something.
Yes, sir. Please, sir. Dr. Anant Kumar, sir. Please unmute.
Yeah. Can you hear me now?
Yes, sir.
Yeah, I'm saying when there is a bland thrombus and it has not come out and it is adherent to the vessels, then one of the procedure you can do it. Actually, this procedure has been described and done by vascular surgeons. You don't have to ligate it completely. You compartmentalize it. So what you do, you take a Prolin suture, go from anterior wall and posterior wall tight, so that if it is the, it become a 3 component. So there is you put 2 sutures. So the IVC, which is now a big lumen, is now become converted into 3 small lumens. So blood will flow, but no major thrombus will go up, and it will prevent embolization of the bland thrombus. And your vena cava is also patent. Like blood is flowing, less blood is flowing, and slowly it will take care of it. This is known as compartmentalization of the IVC. Very well described procedure, which I often do in this situation. and you can avoid putting the filter.
There was a question. Renal vein without right renal artery. Amlesh sir, can you just give an answer?
Ginil, come again. Ginil?
Ginil, will you repeat your question?
Without clamping right renal artery, because it can cause sometimes thrombosis and renal ischemia. So probably that is the Amlesh sir answered this.
Dr. Amlesh said, do you have any comments for that? We have very less time limit left. Let us move on to the next topic.
Raghu, can I just quickly ask one question if you don't mind?
Yes, sir.
My question is for Amlesh sir. Sir, especially when you're doing the dissection for the left-sided renal mass with IVC thrombus, how do you sequence your dissection once you have got the embolization done? For example, if you have got the renal artery embolization done in the morning, would you first go and tackle the IVC thrombus, or would you first mobilize the kidney? And how do you handle this issue of the whole mesocolon and the left side colon being there? Since you are operating on both the sides, do you go transmesocolic or do you reflect the colon and then do the dissection?
Dr. Amlesh, sir, this question is directed towards you. Hello?
I think we lost Dr. Amlesh said, sir, may I ask the same question to Dr. Anand Kumar?
Yeah. See, if the renal artery is already thrombosed, then it is always better if you can tie the renal vein. And then once you tie the renal vein, cut the renal vein. Even if the thrombus is there, if you tie it with the abdominal tape, it will stay there. Then cut the artery, because then you will see the artery. And you can remove the kidney and then go to the IVC, or you can stay there. Once the artery and vein is cut, then you start mobilizing the IVC above and below and all the lumbar vein. And then when all the lumbar veins are clipped, it is always simpler, just put a clip on them. And then you have taken the control left side above and the right renal vein. I usually don't put the clamp on the right renal artery and just leave them and just put the clamp on the right renal vein. It just kidney gets swollen up, but for some time this will happen. And when you release it, it will become all right. And with that sequence, you can go ahead.
So when you tie off the left renal vein, there is no problem about the embolization, or do you have to first control the IVC above and below before you tie the renal vein?
See, what you are doing it, you are tying the renal vein with the abdominal tape. And so the part of the thrombus and the renal vein will get tied up. So that part is there, and distal part you have already cut, and you have, this is now with the kidney. You can put a gas piece there if you're not removing the kidney. And then that part will stay there. And then you can mobilize the IVC above and below.
Thank you.
There is a question to Dr. Raval. Dr. Raval, sir, is online?
Yeah, I am there.
Sir, what are your indications for putting IVC filter, retrievable IVC filter, before performing IVC thrombectomy?
No, but I think IVC thrombectomy, we cannot put IVC filter because
no, it's a
general
retrievable,
indication.
retrievable filter to
Even
prevent.
retrievable, yeah, even retrievable, because generally we put IVC filter for the deep vein thrombosis, so that it has to be infrahilar to reduce that thrombus coming up into this thing. If it is you are talking about tumor thrombus, that can go sometime to the pulmonary artery or vein.
To prevent
tumor
thrombus migrating.
Yeah, I have never done it. I have never seen people doing it. But I have seen thrombus going into the heart and going to the pulmonary artery. And I could not do anything in that case here in Rajiv Gandhi, but I discussed with our friend Chris also. They have their cardiac surgeon. They immediately open and they remove the tumor which has gone, especially if it is causing problem. But putting a filter above the thrombus, I have not done it. And I have not seen being done. Maybe somebody else can share his experience.
No, we have done a couple of cases.
Okay, that's great.
If the distance between the upper margin of the thrombus and the inferior margin of the hepatic vein is 4 centimeter, we can put the retrievable filter just 3 to 4 hours before the surgery. We can perform the surgery and we can
then remove it off.
Yes,
I've not done it. Sorry.
and it will be put through the jugulars.
Yeah.
It costs about.
But we do regularly for deep vein thrombosis when we are going to operate them. But we put that filter infrahilar region, infrahilar IVC.
Yes, sir. So these cases of sudden intra deaths have been reported even for renal vein thrombus.
Yes.
Not for IVC thrombus, even renal vein.
Yes.
Renal vein thrombus can happen while mobilizing the kidney. So in some selected cases, it is preferable to or better to put this retrievable filter. We have a shortage of time. We will move on to the next topic. I request Dr. Hemang Bakshi to talk on the role of cytoreductive nephrectomy, evidence and indications. I request him to give practical aspects. I will ask him to wind up in probably 5 to 6 minutes or probably less than that. Thank you, Dr. Hemang. Dr. Hemang, are you online?
Yeah, can you hear me?
Yes, sir. Please give practical tips.
Yeah, so I am trying this.
We have one more talk by Dr. Sanjay Adla.
Just give me a moment. I'm trying to organize the screen share thing.
Sanjay, meanwhile, arrange your slides. Sanjay, next is your talk. Sanjay, are you online?
Yes, I am, Raghu.
We will move on to the last one.
Please move on with Sanjay and I'll get...
Sanjay, go ahead. Dr. Sanjay would speak on systemic treatment for metastatic RCC. He is going to speak on urologist perspective, not on medical oncologist perspective. So it will be very interesting for all the urologists. Sanjay, please go ahead.
Thank you very much, USI and Raghu for this. So I'm just trying to be as brief so that there is a take-home message from this. So first step would be anybody who comes to you with a metastatic renal cell carcinoma, the first thing you have to do is score them based on the IMDC stratification, because this is the most critical bit. When Hemang sir talks about, he will say that it only needs to be done in favorable or intermediate risk ones. You should not be doing it. So it's the same thing with respect to treating them with medication as well. It has got quite a bit of importance, and these are readily available for you when you see them for the first time. So the first step when you see a metastatic renal cell carcinoma patient is put them on the IMDC risk stratification and then decipher and say, are they favorable, intermediate, or poor risk? So even they don't have any of this risk factor, they are favorable, 1 to 2, intermediate, and more than 2, it's poor risk factor. The reason for that is, if you look at this is the tyrosine kinase inhibitor era, there is a huge difference. So this helps you in telling the patient, saying that, okay, you are in the favorable risk. The median overall survival is almost up to 4 or 3.5 years. So it does help you in the counseling. So that's the first step. So when you see a metastatic renal cell carcinoma, first step is to do the IMDC risk stratification. The second is doing a biopsy. And I'm not going down the line of cytoreductive one, saying that this patient is not having the cytoreductive nephrectomy for whatever reason. So we need to know what kind of a histology are we dealing with, because almost all the trials, all the evidence is with respect to clear cell renal cell carcinoma, and the guidelines are pertaining to that. So it would always be useful for you to know, are you dealing with clear cell renal cell carcinoma? If you look at the medication as such, from almost all the 1900s to up to 2005, there hasn't been any advance with respect to renal cell carcinoma. And the first thing that came online were the TKI inhibitors, sunitinib and sorafenib, and they ruled the roost from 2005 until 2019. They were the baseline treatment for metastatic renal cell carcinoma. So TKI inhibitors, then started with the everolimus. So all the tyrosine kinase inhibitors are NIPS. These are the mTOR inhibitors, temsirolimus and everolimus. Then started the antibodies. Antibodies is mainly, there is only one antibody, which is the bevacizumab. And then the more recent one, PD-L1 and PD inhibitors, all the immunocheckpoint inhibitors. And they started off from around 2015, and now 2020 is when they have taken on the overall management of metastatic renal cell carcinoma. So these are the names. They all, the tyrosine kinase inhibitors are the NIBs. Then you have the monoclonal antibodies, then the mTOR inhibitors, then you have the immune checkpoint inhibitors, commonly pembrolizumab, nivolumab, and atezolizumab. So whenever any metastatic renal cell carcinoma is measured, we tend to go by the RECIST criteria. This is number of metastases. You tend to count, the maximum you count is up to 5, and you go by the largest length, longest length, other than the lymph nodes, which you go by the short axis. And that's what becomes your baseline. The sum of the longest diameter of 5 lesions becomes your baseline number. And when you give them treatment, that's what you use to assess whether they have responded or not. And the response is, if you say partial response, 30% decrease in the size of it, stable, there is no increase in the size of it, progression, 20% increase in the size of them. So this is the RECIST 1.1 version of the RECIST criteria, which is from 2009. So if you look at, this is the 2019, so just a year ago, so from 2005 to 2019, the first line treatment was sunitinib or pazopanib. So we were still in the TKI era for favorable risk, and the intermediate and poor risk, we were going into the PD-L1 and PD-1 inhibitors. Whereas if you look at the main difference has been between 2009 and 2020 was the publication of this keynote trial 426, wherein they had 860 patients divided between pembrolizumab plus axitinib versus sunitinib. So if you think for the last 15 years, sunitinib was the baseline treatment, and they looked at all the patients in this cohort. And what they found is pembrolizumab and axitinib is better compared to sunitinib. And when you look at the numbers in almost all subcategories, the sunitinib was inferior to pembrolizumab and axitinib. And when you look at the numbers, there is a difference of the overall response rate, 60% to 35%, and as well as the overall survival and the cancer-specific survival. So as per EAU 2020, whether they are favorable risk or intermediate and poor risk, the first line treatment is pembrolizumab and axitinib. So a clear cell renal cell carcinoma, whether they are favorable or intermediate, go down the line of pembrolizumab and axitinib. Especially in India, where they can't afford, the second line options would be pazopanib or sunitinib. Currently, pazopanib is slightly cheaper compared to sunitinib, but that is the second line. So in alternative treatment compared to pembrolizumab and axitinib, which is the first line, is sunitinib or pazopanib. When they progress, then you go down the line of the other treatment options. So as I have said, the first line would be for you to know whether they are favorable, intermediate, or poor risk, and you don't, though it helps you in telling them where they fall with respect to the overall prognosis. The current treatment plan is axitinib and pembrolizumab is the first line treatment option. Thank you, Raghu.
Thank you, Sanjay. We will move on to the previous talk. Dr. Hemang, are you ready with your talk? Yeah. Please go ahead. Role of cytoreductive nephrectomy. What is the evidence and what are the indications?
Just a moment.
This is the last talk. Still around 220 people are viewing this. We have to wind up as early as possible. It's 8:40 now. Are you ready, Dr. Hema?
And around 70 on Facebook.
Could you see the screen?
Yeah.
Okay.
Kindly share your slides.
Yeah, can you see it now?
No, not yet.
We can see your video, but we are not able to see your presentation.
Oh.
Raju, you said something. Raju?
Because my presentation is open here. Just a moment.
We are having 220 on Zoom and 71 something on Facebook.
I'll give it a last shot. If I can't, I'll just quit. I mean, I have the.
You can speak. Left side corner, there is a share.
Yeah, I did that, sir. So
it's okay, sir. You please
click on the share.
Yeah.
So can you see?
Then you have to click twice.
Your presentation.
You
Which
click
is
share,
behind-
then there will be again share. You click that also.
I did both. Now I'm opening the presentation. Can you see?
No.
Okay,
No.
so there is some problem.
You can talk briefly on this role of cytoreductive nephrectomy, sir.
Yeah, just I tried once. Otherwise, in 2 minutes I'll summarize what I had to say.
Yeah, please.
Sorry about this, but this has never happened. But still, let me try advanced. No, again, this is 1 minute, and that's it. There is a problem. Anyway.
Can you summarize?
Sorry, but I'll just summarize what I had to say about cytoreductive nephrectomy. I'll have to speak. Now, Adla has already mentioned about the changes which has happened over the last couple of years. And cytoreductive nephrectomy was pretty much the standard treatment because the literature did show before the TKI era in 2 trials that there is a survival advantage of more than 2.5 times over not doing a nephrectomy and giving systemic therapy. Then came the Carmena trial in 2018, which said that sunitinib was non-inferior to a combination of sunitinib plus nephrectomy. And in fact, the outcomes of sunitinib were better than the combination of upfront nephrectomy followed by sunitinib in some aspects. And so they concluded that cytoreductive nephrectomy is a bad idea and should not be done. The criticism of Carmena was that it mainly had poor risk and intermediate risk patients and very few low risk patients with limited volume of metastasis. Then there was another trial called the Certime, in which the sequence was changed, nephrectomy followed by sunitinib versus sunitinib followed by nephrectomy. Again, it showed that sunitinib upfront had better overall survival than the other way around, and progression survival was not much different. So these 2 trials suggested that we should not be doing cytoreductive nephrectomy anymore. There were a lot of problems with these trials, poor accrual, the number of patients were of different spectrum than what we see in clinical practice, and they used the MSKCHS criteria rather than the IMDC criteria, which we do use normally. Now, apart from these 2 trials, there have been various studies which have showed that cytoreductive nephrectomy should be a part of treatment. And what patients should be offered this cytoreductive nephrectomy? Now, over the last 2 years, we have the indications have changed. We don't offer it to all comers with metastatic disease. We select those patients who have oligometastasis. For example, a large tumor, 14 centimeter tumor with a venous thrombus and 2 lung metastases. We certainly would offer him a nephrectomy, especially if the patient is young and fit. So these are the patients you would want to do cytoreductive nephrectomy, but not for those patients who have a limited primary tumor volume, extensive metastasis, and no symptoms. So the indications for a cytoreductive nephrectomy right now would be, number 1, a large symptomatic tumor, which has, the patient has hematuria, the patient has a thrombus, which is at risk of embolization, and limited number of metastases in the body, which can either be treated by medical therapy or which can simultaneously be removed in form of metastatectomy. For example, if there is a single lesion in the bone or a couple of lesions in the lung, which you can take out or even radiate. SBRT is also coming back in some way in renal cell carcinoma. So, and that if you tackle these oligometastases at the same time, what you would do is delay the time for systemic, when the patient would receive systemic therapy. So only these patients right now, favorable in risk disease with oligometastasis and large and symptomatic tumor, should be offered cytoreductive nephrectomy at this point of time. I think this was the gist of the summary. I'm sorry again about the presentation.
No, it's okay. Thank you, Dr. Hemang. So with this, we have come to the end of this webinar. I thank President USI, Dr. Anant Kumar sir, Honorable Secretary, Dr. Rajiv TP for their support. And I also thank Chairman, Indian School of Urology, Dr. Rajiv Sood, and Co-Chairman, Dr. Arun Chawla for their support and encouragement and for giving this opportunity to me. And I also thank all our faculty. They did excellent job and they shared their knowledge. Thank you, sir. Thank you, everyone. And lastly, all the viewers, thank you for staying with us. Even now, around 170 are with us. Thank you, everyone. And
Thank you, Raghu.
I would request Rajiv TP to give the closing remarks. Rajiv or Anant Kumar, sir.
Dr. Raghu, thanks for a wonderful moderation. All the speakers have presented the topics and there were good discussion and good number of questions were going in the chat box. And I really congratulate you for preparing such an extensive, such small aspects on RCC. It was really an update on RCC. It has been quite beneficial for all the viewers. And again, once again, thank all the viewers, especially the faculties, for a wonderful webinar on update on RCC. And this is an effort of the USI and Indian School of Urology. And I thank Dr. Rajisu, the chairman, and Dr. Arun Chawla for helping me in arranging this webinar on RCC, and Dr. Anand Kumar, the president of our society, for giving all the valuable guidance and support. So USI will have more webinars every weekly on various aspects, and I request all the members of the USI to be a part of all the USI webinars. This is non-sponsored, not supported by things, solely conducted by USI and Indian School of Urology. Thank you all once again. Good night.
Thank you. Thank you.
Thank you, Raghu. Thank you, everyone.
Good night,
Thank
Raghu.
you.
Grand job. Thank you so much.
Thank you, everybody. I'm Dr. Sood.
Thank you, sir. Thank you, sir.
Hello, sir. Thank you.
Thank you.
Ginil,
Hi.
thank you.
Thank you very much.